Hello there, my name is Galvani, I'm a diagnostic radiologist. In a few moments I'm going to share the screen of my workstation so we can read and report some CT scans from the emergency together. We're going to roll the images, look for pathological signs of disease, and eventually reach a diagnosis for each and every case we read. Then I'm going to write down the report and comment on terminology, what is important for the referring physician, what should and shouldn't be on the report, and etc. So if that's what you're looking for, stick around and let's get to the first exam. And it's a head CT scan of a young male patient. He has suffered a motorcycle crash 4 days ago and refers headache, dizziness, and has a black eye. So we could be facing here a case of a severe skull base fracture. Let's open this exam so we can rule out such very bad disease with a terrible prognosis. And I guess you guys you can see what I see, just checking. And this is a bone window. I'm just going to first of all check for soft tissue lesions. It's a head trauma that occurred 4 days ago, so the patient is clearly out of risk of death, because severe head trauma leads to death quite easy and quite early if it's not treated properly. So this patient surely isn't going to die, but he could be facing very severe prognosis without proper treatment. So now we're going to look for fractures. Mandible, the maxillas are fine, zygomatic arc, clavus, cervicocranial transition is okay. Petrous bones are fine. Temporal bones and temporal mandibulary joints also are okay. Carotid canals are fine. Really can't see any sign of skull base fracture, so I guess this was just a false flag, a false alarm. This patient has no fracture. I'm just going to hit some MPR here to see if we spot any orbital lesion, soft tissue lesion, or fracture, because orbits are quite fragile. Now intra and extra conal spaces are fine. The eyeballs are properly placed inside the eye sockets. Zygomatic arcs are indeed normal. And the temporal mandibular joints are fine. Petrous bones, petrous pyramids are preserved. This is a normal bone scan of the skull. No signs of fractures or disease whatsoever. So, lastly, we're gonna look for brain damage. There isn't soft tissue nor bone damage. There could be some kind of brain damage. There is some densification and thickening of soft tissue parts on the right side of the frontal region and the face. I suppose this is some kind of residual hematoma, but very mild disease, very unlikely to be the motive of this scan 4 days after the accident took place. And this might be what the referring physician wrote about a black eye. This patient clearly has a facial hematoma on the right, but this isn't a sign of skull base fracture, as we have ruled out already. So, excuse me. So, yep, this is fine. Posterior fossa, brain parenchyma, no signs of contusions, hemorrhage, or anything else that could point to a actual brain damage related to the head trauma. So this is a nearly normal scan. Let's just grab a template. Of course, I have a template for a normal CT scan of the head. I'm just going to copy and paste. Copy and paste it. I'm just going to sip my coffee because coffee is the best. Yeah, that's awesome. So, encephalus. No injury to the brain. And I'm going to quickly report that thickening and densification of soft tissue parts on the right side of the patient, because that hematoma is has been seen on the physical exam, so we have to report it. I'm going to put a footnote on this report mentioning that radiological sign. So, and we are done. Let's get to the next exam. And it's a lumbar spine of a 75-year-old male patient who complains of difficulties to walk. He says there is no trauma, but he has difficulties to walk. We could be facing here a case of osteoporosis, severe osteoporosis with pathological fractures due to stress, due to overload and insufficiency fractures of the spine. The download is done. Let's load up the images. We have both a soft tissue and a bone recon. I'd rather just use the soft tissue recon because I can see enough bone and neural structures and muscle and all this stuff just by looking at this recon. Oh, there is something very ugly right here. Could be an acute fracture, could be a osteolytic lesion secondary to something else. This clearly isn't an easy exam. There seems to be some soft tissue extension of this fracture to adjacent structures and to the vertebral canal. All kinds of degenerative disease of the discs. This should have been an MRI, but it's firstly a CT scan. So let's see what we can do. If it's a scan, it has to be reported, and scans don't report themselves. So as I said, there are a bunch of small fractures and large fractures to L3, L4 vertebrae. Yeah. Bulging discs all over, severe stenosis all over, arthrosis as much as it's possible, and there seems to be some osteolytic lesions just like here and there and there, so this could really be like that and that over here. So this could be indeed a case of secondary disease, some kind of metastatic disease, which could be much more clearly evaluated on MRI scan with contrast injection, of course. So I have a clear extension of this lesion to soft tissue parts. You can see here and there. So I'll have to report it just like that. So there is moderate stenosis of these foramina. Yeah, moderate stenosis. Mild stenosis of L5-S1 and L2, L3, L3, L4, L4, L5 are moderate. And I can also say there is moderate stenosis of the vertebral canal from L2 to L5 easily. I just confirm it on the axle. On the axle I can readily see. Yep, this is at least moderate stenosis. I could even tell this is severe stenosis because there is some other soft tissue lesion reducing the size of the vertebral canal. You can say this is moderate and the rest is fine. This is 2, 3, 4 and 5. So 4 and 5 have osteolytic lesions. These are small nodes, intravertebral herniations, but these ill-defined osteolytic lesions aren't just herniations. If you notice, this osteolytic lesion doesn't have sclerotic margins as these lesions right here, who are degenerative in nature, of course. See, sclerotic margins, osteolytic. So this is degenerative, this is degenerative, this is in secondary, but this isn't the same. This has no sclerotic, this is ill-defined. So if it's ill-defined, it's dangerous, it's very, very ill-defined. So I guess these are actually tumoral, neoplastic, secondary, metastatic lesions. So let's report it, because this exam, no matter how hard it is, it won't report itself. Yeah, coffee always helps. So I'm going to grab one of my templates that describe severe disease, and I'm going to report it. There is diffuse demineralization of bone, which is a very clear sign of osteoporosis, very common on the elderly, especially over 65 years old. And I'm going to say vertebral bodies have normal heights and marginal osteophytes. And And now I'm going to describe the osteolytic lesions. This is L3, L4, L5. So, small nodes, which are intravertebral herniations, I have described those. And certo. Yep. Now we're going to describe the discs herniations that come from 2, 3, 4, 5, and S1 we have 1, 2, 3, and 4 disc herniations or bulging discs. So, yeah, and we have to also describe the degenerative signs on facet joints. I can say these facet joints are really bad, but the others aren't really that bad. They are quite preserved, so I'm going to classify this as moderate disease of the facet joints. And right here you guys can see there is signs of gas inside this intervertebral disc, which points out to severe end-stage degenerative disease of the discs. And there is also partial ossification of the discs, which is also a sign of end-stage degenerative disease of the discs. So this is quite severe and really common for elderly patients. So we get used to reporting this kind of signs eventually. So stenosis. Let's go for vertebral canal stenosis. L5S1 is fine. L4, L5, I can say it's moderate. L3, L4, it's severe. Moderate, normal. So moderate and severe. So this is 3, 4, and 5. L3, L4 is severely stenotic. Almost no canal is left. And let's once again classify the stenosis of the neuroforamina. So mild, mild stenosis, moderate stenosis for sure. So we have mild and moderate in between. So mild stenosis of the neuroforamina of L2, L3 and L5, S1, and moderate stenosis of the same foramina on L3, L4 and L4, L5. Yeah, this is it. And lastly but not least, you have hypertrophy, diffuse hypertrophy and fat infiltration of the perivertebral muscles. Oh, I also have to say there is an apparent soft tissue mass taking over the vertebral bodies on L4 and L5. I'll just try to measure this, 44 millimeters, and I'll just give another measurement. I could say it's right about here. It's 44. So I can see there is a apparent soft tissue lesion because there is no contrast injection, and even if there was contrast injection, contrast enhancement, it's quite difficult to be certain about soft tissue lesions on a computed tomography scan. So it's much better, way better to have an MRI. I'm going to suggest an MRI on the end, as a footnote of this report. So this way we can cover up every possibility and be actually useful to the referring physician that has no idea this patient might have a kind of a tumor, because on the clinical data we received there was no mention of such a neoplastic disease. Yeah, coffee. So let's summarize the report to make it easy for reading and whatnot. Bulging discs. Oh, there is also thickening of the yellow ligaments, as you guys see here. This is quite normal, and this is a factor that leads to the causes stenosis of the vertebral canal, of course. It occupies partially the canal. So, let's copy and paste the stenosis signs and descriptions to make it easier. This is the most important part of the report. I'm going now to comment on the osteolytic lesions. L4 and L5. Just reading what I just wrote. Make sure I didn't make a huge mistake. Now a footnote to suggest an MRI. And that's it. We are done. Excuse me. And it's gone. trash is clean. Now let's grab ourselves a abdominal CT scan. This is a 94-year-old female patient. This is an unenhanced CT scan, and it says she has jaundice and abdominal pain. So I'm going to hit download so we can get the images, and I'm also going to get my template for abdominal CT scans of an old patient, female patient. So we need to wait another 15 seconds for the exam to reach us. It's a great time to take a sip of coffee, even cold. This coffee is awesome. And this is a terrible end stage case of some kind of horrible CT scan of the abdomen. Some kind of end stage disease, surely. And let's see what we can do, because we have no contrast enhancement. We have so much movement artifacts. Can't really tell much, but I can write just. Did you see it? Did you see the disease? The disease is right here. I can't really tell. And I can also tell this is an acute abdomen. There is pneumoperitoneum. There is free air inside the abdominal cavity, which is never good. This just can't be good. And I can see here we have a major ascites. We have lots of pneumoperitoneum, which is free air inside the abdominal cavity, which is a sign of acute abdomen. We have a densified epigastric hernia, which could be an acute hernia. Is this colon? This might be ileum. This could be ileum. It's really close to the herniation. This isn't free air. This is ileum. This ball. There is a lot of free air. Also, there is a lot of densification of the fat planes of the cavity, which is really bad. Major ascites, atrophic uterus, partially distended urinary bladder. The soft tissue parts are all densified and thickened. This is a very ill patient. Bilateral pleural effusions with all kinds of things to the lungs. This isn't our focus, so let's focus on the abdomen. We have an atrophic pancreas, a atrophic spleen, a majorly atherosclerotic aorta. We have a bilateral chronic kidney disease, and this is an atrophic kidney, so this kidney is gone, and this kidney right here is partially gone. Also, the case of the cause of the jaundice, we have here the gallbladder, as bad as we can see, because this is a very badly done exam of a very badly diseased patient. So there is major calcified content inside the gallbladder. These are stones, calculi, and also the hepatocoledocal duct, the extrahepatic biliary tree, is all filled up with stones. So there is choledochal obstruction by gallbladder stones all over the extrahepatic biliary tree. So this is the cause of the jaundice, but I couldn't really grasp the cause of the pneumoperitoneum. There should be some kind of visceral rupture of the digestive tract, maybe the stomach or the duodenal arcs, or even this loop of ileum right here, or jejunal, which seems way too close to this ventral herniation. Maybe there is some kind of perforation somewhere, we can't really tell. Oh, and the patient also has a surprise. She has a stent on the left external iliac artery. So, this is a major case. I'm going to report it so we can get to another less difficult case. So, this video can be of some use for you guys that are starting out on this radiology thing. So let's start, because as you guys know, exams won't report themselves. Yeah, very badly done exam, no contrast enhancement, and severe disease all over the abdomen. Of course. I can say the liver is okay. Just going to mention the ascites and the pneumoperitoneum. Now I'm going to say the gallbladder is sick, it's altered, has stones in it. Let's measure this approximate size of the biliary tree, extrahepatic biliary tree, about 1.7 centimeters. It's filled with stones. This isn't the portal vein. The portal vein is right here. This is the portal vein. This is the biliary tree. Just for you guys that are in doubt, that could be screaming on your chairs, to your television, say this isn't the choledochus, this is the portal vein. No, this isn't. The choledochus is here, the choledochal duct is this one, and the portal vein is right here. This is an unenhanced CT scan, and the stones are hyper intense, hyper dense, hyper attenuating lesions. So, measure this large cyst right here so I can report it. Adrenal glands are fine. Pancreas has normal size for age group. So forgot the size of the cyst. What size it is? Is it 28? There is severe atherosclerosis of the aorta. Lymph node enlargement. When you see any lymph nodes, there should be lymph nodes everywhere, but it's really hard to tell. Some adenopathy, some lymph node enlargement. You can see here. So there is. Why shouldn't there be? There should be enlarged lymph nodes in such a severe disease. Just makes much more sense this way. So, there is an atrophic spleen. Tuberculosis of the colon, not that I can say. No tuberculosis. Okay. Atrophic uterus, bones, other and metastatic lesions to bones. Now let me describe this prosthetic right here, this stent. So we're done. And lastly, let me remember. Now, there is this ventral herniation right here. And we finally reached the end of this report. Now let's summarize it. Lots of edema everywhere. In Portuguese we call it anasarca. I really don't know the terminology in English. Maybe it's just diffuse edema. It's much simpler. I guess anasarca comes from the Latin terminology, which isn't so popular in the United States or any other English-speaking country. We just like it in Brazil. So there are gallbladder and biliary duct stones. There is a atrophic spleen. Atrophic uterus and a herniation, ventral herniation. Are we done? Oh, lymph node enlargement. Retroperitoneal lymph node enlargement. I have to say that. This is important. Let's look at the urinary bladder is okay. Lots of arthrosis and whatnot. This is so severe. It's quite easy to miss something, so we just have to be sure we report the major causes of this acute abdomen, the really important features of this group of diseases all meshed up together, so we can actually help the referring physician to make a decision about about how to take care of this patient. So this is it. We have finally finished this exam. This was a tough one, but I'm pretty sure we learned a lot. So let's sign it off. Clear the cache and go to the next one. So the next one is a chest CT scan of a 58-year-old male patient. It says she has chronic hypertension, he smokes, and he has had pneumonia and tuberculosis, COVID and surgeries. So this looks like another tough case. Stay tuned. It's about to end the download, so I'm just going to grab my template, copy and paste template. It's here. Also, we have already downloaded the exam. Let's load. This is the chest, the lung recon and window, and this is the soft tissue mediastinal reconstruction, so we can also look for soft tissue disease. This is a very thin patient and he seems quite normal. No major architectural distortion of the lungs. Some micronodules, cortical micronodule, non-calcified. Yep. Some pleural thickening, each by itself could be nothing, but we are supposed to report that, so there is quite a lot. This is a big nodule. Remember, he's a smoker, so this is 1 centimeter. This is of concern. This is also of concern. 6 millimeters. Yeah, I don't see much emphysema, not bronchiectasis, nor parenchymal distortion that could relate to tuberculosis or heavy smoking, but this patient indeed has a bunch of nodules and micronodules, especially on the upper lobes, with pleural thickening, irregular pleural thickening, and some bands on the apex of the superior lungs, superior lobes. And what else can we see? Inferior lobes look fine. It's quite odd to have pleural thickening on the upper lobes and not on the bases. I guess we have some thickening on the bases, just here. Some basal pleural thickening on the right. Most probably this patient has had a pneumonia with a pleural effusion, and this is just scar tissue related to that infection, but we can't really tell that for sure. So we are going to report it. I'm just going to measure here the ascending aorta. It's okay. There are some calcification on coronary arteries and on the aortic arc, some calcification on mediastinal lymph nodes, and esophagus. Esophagus is fine. Fine. And lastly, I'm just going to hit the MPR button and look for collapsed, fractured vertebral bodies or secondary bone lesions. No secondary, no fractures, just degenerative disease, which is compatible, is fine, common, and unremarkable for this age group. So let's report this and get to the next exam as quick as we can. No pleural effusion, but there is a thickening of the pleural surfaces on the right. Micronodules, pulmonary microneocortical, non-calcified pulmonary micronodules that reach 6 millimeters of diameter. And that particular nodule right here, this posterior segment of the upper superior right lobe. So let's call this a separate description just to draw attention to it. Take a closer look. It has irregular margins and is non-calcified. Let's look at it on the coronal plane to see if it's discoid in shape or round in shape. It's round and on the coronal plane it even looks like it's spiculated. So this clearly is a sign of something else that should be closely watched. There is a pleural thickening right next to it, so it could be just a oddly shaped parenchymal band. It happens, but I have seen tumor arise from scar tissue one too many times on CT scans of the lungs, so you really can't be too careful with this case. Let me measure it once more. I'm going to say it is 9, almost 0.9 centimeters on the graded axis. No calcifications. Irregular margins and quite big. So the rest of the parenchyma is fine. Yep. There is atherosclerosis of the aorta and the coronary arteries, and lymph node calcifications on the mediastinum. So we are done. let's just summarize to make it easier to read, and the referring physician will be much happier to read just a tiny bit of text and not the entire report. So that nodule, the bands, the atherosclerosis, and the residual calcification of lymph nodes on the mediastinum, in the mediastinum. So we are finally done. It's signed. Cache is clear, and let's grab another exam. This is a head CT scan. This is a male patient, 43 years of age, no clinical history. Let me hit download, as it will download the exams as we load here the clinical history. It says it's head trauma. He suffered head trauma 1 year ago. That's really odd. Head trauma 1 year ago. CT scan on the emergency. It says it's urgent. That's really odd. Let's load the images that have already arrived. We're going to put a soft tissue window right next to the bone window. Soft tissue. This is a old scanner. This is a poor quality scan. Patient shook his head while scanning the posterior fossa. So this is even worse. But I guess we can see major disease if there is any signs of it. So the parenchyma is fine, no calcifications. Let's see the eyes. Orbits are fine, masticatory spaces, buccal spaces, and the upper portion of the neck, salivary glands, perivertebral space, cervical cranial transition, also the ears. I don't have to do this, I can look at here. So bone, let's look for fractures, deformities, or lesions, focal lesions, no focal lesions. Zygomatic arcs are perfect. Mastoids, temporal bones, petrals, pyramids are fine. Internal ear structures are okay. Carotid canals are okay. Some tiny bit of fluid inside the left sphenoidal sinus. This is quite normal and usually, most of the time, asymptomatic, not related to the case itself. So let's now focus on the brain, see if we can find some justification to do a urgent CT scan of the head 1 year after a head trauma. I can't really tell. As far as I can see, this is a normal scan. Really normal. As normal as it gets. Thank God. This has been a tough. Oh, there is still coffee here. Cold and awesome. So, if you haven't already, this is the time to hit that like button and consider subscribing to the channel. Thank you so much. I should have said that a bunch of times, but I was just too much distracted on trying to survive reporting those last terrible exams, as you may have noticed. So this is a normal exam, so I copied and pasted and reviewed the template. I guess we're done here. There isn't even any signs of arterial calcification, so this is really a normal exam for us, considering its technical difficulties. So can't really tell much. Let's sign it off, clear the cache, and get another exam. So let's grab a chest exam. Here we are, chest exam. This is a 31-year-old female patient. She says she has a cough, a persistent cough, no sputum, and has never gone through surgery. So this is an unenhanced CT scan of a young female patient from the emergency chest. Let me grab a chest CT scan template. We are about to finish downloading this exam, and we are already almost 1 hour in. So let's see what we can tell. 10 seconds, last 5 seconds to finish. Just a couple more seconds so we can actually look at the images. Yep. And this is it. Yep. This is lung window, and this is soft tissue recon and window. Let's look for outside of the lungs. Look for lesions outside the lungs, so we can see there are enlarged axillary lymph nodes. Usually there are cervical lymph nodes enlarged as well. In this case there are a lot of cervical enlarged lymph nodes. The largest lymph nodes are over 2 centimeters on the short axis. Yeah, 2 centimeters on the short axis approximately. So this is something to report. I'm going to report it before I actually miss it. So we don't actually know why the patient is doing a chest CT scan just for cough, so that might be something else. The thyroid gland is fine, even though there is adenopathy outside the chest. There is no such disease inside the chest on the mediastinal nor the ila, the pulmonary ileum, the pulmonary pedicles. So mediastinal is free. Let me measure the ascending aorta. It's normal. The pulmonary trunk also is normal, and the heart is normal. This quantity of fluid on the pericardium is also normal. Bone. There is a bit of degenerative disease, a bit of spondylosis on the dorsal spine. I'm going to report that now. Just so I don't miss it. And lastly, let's see the lungs. Slowly but surely, are there anything Is there anything wrong with the lungs? No, can't really tell. I guess it's okay. No disease. So just the enlarged lymph nodes. I'm just going to zoom in so you guys can see. See? These lymph nodes are definitely wrong. It should be like this. It should be really tiny and much less numerous. So this is axillary enlargement of lymph nodes. Also right here on the cervical thoracic transition, I can see right here infra-eoid carotid space and visceral space lymph nodes are enlarged. Also posterior cervical space lymph nodes are also enlarged, and supraclavicular fossa lymph nodes also enlarged. So there is some kind of lymphatic disease that we really don't know anything about, because we have practically almost no clinical history about this patient. All we know is that she complains of coughing too much for far too long. So let's finish our report and move on. So if you like this video, I'm pretty sure you're gonna like this one. So just click here and keep watching. Please hit the like button and consider subscribing to the channel, and share this video with people you know enjoys radiology and diagnostic radiology. And until next time, I'll see you around.